All right, and Athena, if you can do like 15-second countdown just to let folks enter, and then we'll get started.
Good morning, happy Friday, and welcome to the monthly meeting for the California Collaborative for Long-Term Services and Supports. Today, we're going to have a panel talking about the way they are helping support mental health needs of skilled nursing facility residents in San Francisco. We look forward to having that initial discussion with an opportunity for Q&A following that session. And then I'll provide a quick update on CalAIM and some of the changes that have come as it's moved through the process going to the federal government and through the legislature here in California. And again, opportunity for you all to engage in that discussion following that overview. We look forward to all of your participation. Please do remember to use the chat feature and Q&A for questions throughout, and we will get to them during those two Q&A sessions. So really excited to introduce our first panel. We have Susie Smith, who's the Deputy Director of Policy and Planning at San Francisco Human Services Agency, and Nora Martin White, who's a Senior Planning Analyst, also at the San Francisco Human Services Agency. So please join me in welcoming Susie and Nora as they provide this overview. Thank you so much.
Thank you. Thank you so much, Athena. We're looking forward to presenting some of our findings and kind of corresponding recommendations in this area today. So thank you for having us. You can move on to the next slide. So just briefly, our agenda today for this presentation, I'm going to talk briefly about this particular project description and the background, as well as some of the findings from the study that we did of this issue. And then my colleague, Susie Smith, is going to take over to talk about kind of recommendations that we put together based on these findings, and then potential next steps, particularly for this group that you all can take to move this work forward. Next slide, thank you. This project came to be because the San Francisco Long-Term Care Coordinating Council, which advises the mayor in San Francisco and the city in general on policy planning and service delivery issues for older adults and people with disabilities, requested this study due to anecdotal reports of increased levels of suicidality, acute anxiety, depression, social isolation, and loneliness at skilled nursing facilities during the COVID-19 pandemic. As will likely not be a surprise to anyone on this call, the COVID-19 pandemic highlighted and exacerbated existing mental health needs and gaps in access to support for skilled nursing facility residents, as well as longstanding issues with the nursing home industry. And kind of during the course of this study, several statistics we have about the state of this issue. In a nationwide survey of family members of people living in long-term care facilities, 91% noted a decline in their loved one's demeanor during the pandemic. Pre-pandemic, it should be noted, rates of depression among nursing home residents were significantly higher than community dwelling older adults, and rates of mental health treatment for SNF residents also tended to be low. And so the pandemic just exacerbated these existing issues. And it's, you know, I think really it just makes sense, frankly, that this is happening, given what we know about kind of the impact of the pandemic on SNF residents and staff. In California, SNF residents made up only 0.3% of all California residents, but 22% of COVID-19 deaths. So given kind of these stark realities, the council requested this study to see kind of correspondingly what the mental health picture looked like for these residents. Next slide. So the project objectives were several, and we were fortunate to have a graduate student from UC Berkeley, Carly Clemens, take this on as her capstone thesis before she graduated. So several of the objectives included identifying the needs and gaps in mental health service and trying to figure out the impacts of the pandemic, particularly on mental health needs of SNF residents. And particularly whether kind of the role of telehealth, what the role of telehealth could be in providing mental health services, as well as exploring access to socialization opportunities and kind of how we move forward to a new normal in this environment. And then finally, producing recommendations for best practices and promising approaches to mental health service delivery to SNF residents. And I should note just briefly that in this report and this study, we specifically looked at long-term care residents in skilled nursing facilities and not short-term rehab residents. So we're particularly talking about long-term care residents in these settings today. And the methodology that we used, it was a variety of data sources. So we conducted a literature review, many stakeholder interviews, including focus groups with the ombudsman in San Francisco, directors of nursing services and social services of 4 skilled nursing facilities, several doctors with expertise in nursing home reform and telemedicine, and other advocates and experts in the space. We also conducted a survey of the 18 skilled nursing facilities in San Francisco, 9 of which completed the survey and also participated in stakeholder interviews. We also used some publicly available data sources, including CMS data and also staffing data, as well as trying to really emphasize the resident perspective. We conducted several informal resident interviews via Zoom and used some data from a resident survey shared by one SNF. Next slide. And now I'm going to go into some of the findings based on the data sources I just mentioned. So as I mentioned at the beginning, it was clear in these conversations that the pandemic had really large impact on the mental health of long-term care residents of SNFs. We have several quotes from the survey and interviews that we did, but just to kind of illustrate one, a SNF resident reported, "They want us to stay in our rooms. It drives me nuts. It's just the same old stuff every day." And a lot of the stakeholders reported that, an increase in cognitive decline in many of their residents due to lack of stimulation, and including kind of a speech language pathologist expressing dismay at the decline in residents' cognitive assessment performance. And particularly, I think dining and diet came up quite a bit as well. That like one SNF reported that residents just kind of lost appetite as reported on their kind of PHQ-9 assessments, and that, that the fact that the congregate dining was interrupted just really kind of impacted not only residents' mental health, but also kind of their cognition and their mental health. Next slide. And another kind of example of impact is this came up quite a bit as we did this study in the spring around the fear of reentry, which I'm sure all of us or most of us kind of may be feeling at this time. We can kind of share in this idea that after a year plus of waiting for things to normalize, then kind of trying to resume old routines, kind of is complicated to navigate, given kind of the scary reality of the last year and a half. Kind of as this advocate put it succinctly, people don't get over this, a year of isolation just like that. There was a report from a particular SNF of residents not wanting to resume communal dining, but even kind of more informal activities, like they would, pre-pandemic, many residents would sit by a bird cage that they had in the facility just to chat and catch up and socialize. But even though the SNF had kind of like opened up a little more as we were emerging from the pandemic, residents were reluctant to resume those social activities. Importantly, I think this was a key finding for us, which probably won't be surprising to many of you. Resident needs and like mental health and frankly, just kind of the COVID needs really exceeded caregiving staff capacity. Historically, staff in this industry have had high levels of burnout just due to the nature of the job, and the pandemic added an additional layer of stress. And kind of one director of social services put it, the whole ratio of staff to residents in nursing homes is inadequate, 5 to 6 residents to 1 certified nursing assistant per shift. They don't have a lot of time to chat. They never did. With COVID, it became even more challenging. So I think this just really highlights that that the staff had trouble even meeting some of the kind of physical care needs of their residents, and so kind of had even less time to kind of check on the mental health needs of the residents. Next slide. Kind of to underline this, in a survey of nursing home registered nurses, 72% reported missing at least one necessary care task in their most recent shift due to a lack of time and or resources. So again, just really highlighting that the staff of these facilities were kind of really overwhelmed, and even to meet these basic needs and to kind of meet the demands that COVID-19 and the kind of mitigation efforts put on them. And so it was a very difficult time for staff as well. And that really just goes into, when we're thinking about recommendations and next steps, that it's important to consider whether the staff will be able to carry out those recommendations, given that they're already really impacted. Next slide. We also found that there were several issues, systemic issues with access to formal mental health treatment, and particularly reimbursement rates for practitioners came up. So like this director of social services said, people with mental health needs are rejected from accessing services because of Medi-Cal, and they then can't afford the private providers. You see them and they are miserable, and the behavior makes those around them miserable. And in the survey that we did, in the open-ended question about what the city of San Francisco could do to support SNF residents, several respondents indicated a need for access to psychological and psychiatric providers, just full stop in this space. And then in addition to that, kind of affordable or practitioners that would take kind of these lower reimbursement rates offered, particularly by Medi-Cal. Next slide. We also found within these systemic issues that there was a reliance on psychotropic medications alone over therapeutic interventions. So for example, in the fourth quarter of 2019, 34% of California SNF residents received an antidepressant in the prior week. and 20% received an antipsychotic in the prior week, but only 2% had access to therapy services. And it should be noted that evidence indicates that kind of psychotherapy in conjunction with the use of psychopharmaceuticals is significantly more effective in treating mental health issues than the use of pharmaceuticals alone. And the FDA has cautioned that the use of antipsychotics in people with dementia, which makes up over half of the residents of SNF residents typically, can come with serious risks, including risk of death. And so this was a fairly troubling finding for us, that the SNFs just didn't have access to kind of a review with the psychiatrist or kind of pairing therapeutic interventions with the use of psychotropic medications. Thank you. And then finally, this has been a hot topic in the past year and a half around telemedicine and teleconnectivity. We found in the survey and our stakeholder interviews that there were kind of several issues and considerations around teleconnectivity. First is that not all of the residents in SNF may necessarily benefit from kind of increased use of teleconnectivity. There's, for example, kind of for those in this director quote, for those suffering from dementia, video calling was hard. They would look everywhere but the screen. They could hear their family, but couldn't figure it out. For some, it was quite distressing. So kind of we found that this may not necessarily be the best fit for some residents. For the residents that it could be a benefit, I think the SNFs struggled with both the availability of physical devices and being able to purchase them and manage them, and also kind of the strength of Wi-Fi to handle kind of video calls. In the survey that we conducted, the most frequent response for how the city could help was the need for iPads or other devices to facilitate teleconnectivity. Like this director at one SNF said, we have a very short supply of iPads. We have two total, and that those 2 iPads were kind of split among dozens of residents. And it should also be noted here that kind of many of the residents, even if they were able to benefit from kind of teleconnectivity, needed support to do so. Most of the survey respondents said that kind of most of their residents would need support. And as we noted, the staff are already really overwhelmed and often would kind of not have the time to be able to support a resident to connect to an iPad, to be able to kind of conduct telemedicine visits or kind of visits with family or friends. All this being said, I think that, as the past year and a half have shown, while there's been a huge impact on this population, there's also a real opportunity for improvement because of the national attention that this area, these settings have gotten. As a director of social services at a SNF said, all of a sudden, SNF residents became a huge focus because so many of them were dying from COVID-19. They weren't a focus before, and I'm hoping that they stay in the limelight a little while longer. We need to continue to focus on areas that affect the elderly. So given that kind of opportunity for improvement, I'm going to turn it over to my colleague, Susie Smith, who's going to go over some of the recommendations that we have given these findings and then next steps.
Thanks so much, Nora, and thanks to the collaborative for having us present today. We're really excited to share these findings and also talk about recommendations and how this group might want to partner on any of them. So the first recommendation kind of undergirds all the others, and this is sort of long-term policy change, but it's looking at how do we actually do an overhaul of the status quo issues that Nora had spoken about. So in order to make any kind of feasible intervention, we really need to address some of these systemic issues. So these are things like, improving the caregiving ratios to reflect CMS's recommended hours per day per resident of nursing care, so that we can have, so that nursing staff are not so overwhelmed and can think about more holistic care. Secondly, thinking about the incentives to actually provide mental and behavioral health services for this population. We need to increase the Medi-Cal and Medicare public reimbursement rates, so that providers, are actually motivated to accept and take these patients and clients into their system. And again, this is, federal, and a lot of larger sort of advocacy would need to happen and have been part of agendas over the years. But we just want to emphasize these kinds of issues because it really is important for implementing any other change. Nora had mentioned, the reliance on psychotropic medications in favor of access to therapeutic interventions. And we want to advocate around making sure that any kind of psychotropic medication is coupled with therapy, because all the research shows that together they're more effective. And so kind of taking a deeper look at what's happening around psychotropic meds in facilities, and how we might advocate for more therapeutic interventions. Increasing the presence of RNs in SNFs, and addressing the high turnover rates, so that we can think about having more opportunities for promoting staff retention, the pay issues, the hours. I mean, all of these issues result in not having the optimal level of care at facilities. So we just start there, given the relationship for everything else. And I think as we move forward to these recommendations, I think it's important to note that while these are specific to SNFs, they're also generalizable to other facilities, and even people living, these aspects impact people living in community as well. The next slide. So the next recommendation is to standardize person-centered care, and that the quality of life should be understood as specific to each person. This seems like a very basic concept, and most SNFs have adopted this kind of ethos, as has CMS, but it's expected to be the norm, but there are problems in implementing it because, again, some of the staffing issues. So person-centered care, is associated with significant improvement in residents' feelings of helplessness or boredom. It's associated with increased job satisfaction for staff. And, it essentially says people should be treated with empathy, sympathy, and acceptance. So we think it's important to sort of standardize person-centered care, and for staff to have the capacity to actually implement it accordingly. And again, it's sort of one of these pieces that impacts all of the others. The third recommendation is really advocating for safe resumption of social engagement activities. As Nora talked about, the kind of fear of reopening, and I think that it's daunting, and there'll be a lot of trial and error as SNFs are slowly, reopening and resuming activities. But given the strong connection between mental health and social engagement, and things like, congregate meals, really kind of advocating and pushing for to SNFs to reopen and to be able to address now that we're sort of over the thick of the crisis from a physical health lens, to really begin to address the mental health needs and through social engagement. So then on the next slide, wanted to talk about a few different evidence-based on-site therapeutic practices that we think could go a long way in terms of addressing the mental health needs of people living in SNFs. And these, again, have been studied as being effective at SNFs and in other settings. And so some of them are really simple, like having telephonic outreach, which is a structured way in which trained volunteers we'll just call weekly older adults and check in on them and see how they're doing. And the objective is just to form social connections and facilitate connections to needed resources. So in San Francisco, we have the Friendship Line, which is an example of that. Another practice is a life review, which I think could be particularly useful right now, which is a therapeutic intervention that involves structured evaluation of one's life, aimed at kind of coping with negative experiences and finding positive meaning. And as we enter, this new normal year after COVID, it seems like having the opportunity for both staff and residents to process what has happened and to sort of come together in a structured way and reflect the trauma that everyone has lived through could be really a powerful tool. And then there's a couple others, something called GIST, Group Individual Staff Therapy, which is a sort of a cognitive behavioral approach to treating depression that's been adapted to the long-term care context and has the goal of developing coping strategies. And then Be Active, which is an individual therapy model developed in partnership with caregiving staff, and residents attend weekly individual therapy sessions, and staff receive training on depression and how to implement this kind of approach. So again, these are just things in looking at the literature that if there's some funding and training to bring some resources to the SNFs, we think could have really positive impact post-pandemic. The next one is the fifth recommendation is around training for caregiving staff on mental health and trauma-informed care. Of course, caregiving staff have the most intimate connection with the people in their facilities, and they are the front line in terms of detecting mental health issues. And if they could be trained in recognizing and responding to the mental health needs of the people living in the residencies, it could have a huge impact in terms of making referrals and service connection in this area. And secondly, again, you need the staff and you need the capacity issues addressed, but an important intervention. Trauma-informed care is something that many facilities are aware of, but aren't necessarily delivering in a consistent way or know about. And this is the idea of kind of looking at service delivery from a trauma lens and what people are bringing to the table when they're if they're exhibiting difficult behavior. It's recognizing that people are bringing trauma in the interactions that they have, and after a year in which, again, we've all lived trauma, and this particular segment of the population has lived through more of trauma than any other, really. I think during this pandemic, having a trauma-informed care approach and training could be really impactful. So the year has obviously been really interesting in terms of using teleconnectivity in a new way, and teleconnectivity can serve as a bridge for some SNF residents to connect to loved ones that are out of state, out of area, to connect to healthcare providers and the larger community. And so we have had some really interesting experiments in trying to use this opportunity to bridge the digital divide. But there are a lot of concerns as well. It's not right for everybody. There's been examples of not reliable internet access, inadequate number of internet-enabled devices. Residents really need a lot of staff support to be able to use technology. And even if they're trained, they still need staff there often to help them. And as Nora mentioned earlier, it's not for everybody. It can be, the use of technology can be triggering and agitating for certain populations, like people with Alzheimer's or dementia. But having said all that, it does provide a really good opportunity, and I think addressing the fact that there are internet access issues, teleconnectivity issues in SNFs when we live in California, which is a technology hub, feels again like an opportunity maybe to use the increased awareness of SNFs as a way to try to forge new partnerships with technology companies. So then the next slide, this is talking about next steps, and this is where you all can come in terms of you have a strong advocacy arm and agenda, and thinking about bills that would support a lot of the systemic issues, in particular at the state and federal level. And then at the local level and perhaps even at the state level, I mean, we're looking for opportunities to be able to identify foundations or local government that might want to partner to pilot some of the recommendations, you know, things like the site-based therapeutic interventions, or training all staff on trauma-informed care and detecting mental health issues. And then lastly, you know, we want to think about how does this set of recommendations fit into local master plan, the state master plan on aging, but then also the local playbooks, and what you have groups that are interested in these issues might adopt pieces of these recommendations and embed them into those local playbooks and your local and state advocacy. So there's a lot here, but we really, you know, really hope there's some questions, and we might learn from you in terms of interest in any pieces of this, and how this fits into your agenda, and some of the pieces of the work that you might be able to pilot.
Great, thank you so much to both of you. So there's a lot of information packed into the presentation here. You know, I think a lot of things that folks know to be true, right? But interesting to see the statistics that you were able to pull together. You know, again, the spotlight that's been put on these folks over, you know, the pandemic has really highlighted some ongoing things that I know a lot of folks here have been working on, you know, pre-pandemic to sort of help. So I know there's some comments in the Q&A about, you know, legislation around ownership and transfer. And then, you know, thinking about all the activity that's happening in the legislature around this. I'm curious, you mentioned some things about, you know, network ratios and increasing some of those even, you know, before the pandemic. Were there, if you encountered any problems with just sort of capacity, right? So they just don't have enough capacity to even keep the folks, you know, that need these types of services, and the staffing around that as well. Do you have any reflections on some of those issues?
Yeah, I mean, I think, again, this is where thinking about state and federal advocacy comes into play, right? I mean, the fact that these SNFs are just under-resourced, the Medi-Cal and Medicare reimbursement rates are not high enough. You know, there is, in Biden's American Families Plan, there was $400 billion, for long-term care and, you know, support services, and, you know, and I think that that's part of it. Also looking at wage and equity, and so this is not something that can get resolved. I think we really need an influx of funding to be able to address these capacity issues. But this opportunity, we feel like, given the pandemic, can highlight that and maybe help us elevate them politically.
And one of the questions in the chat was also about how many residents are left during the pandemic. And, you know, if that created more of a ability to think about how we support some of these people at home, right? That some of them could, you know, maybe people weren't working because of the pandemic, so they were able to do some of that. But then once they're there, is there a way to think about, you know, the integration of the, you know, community supports that maybe keep folks that don't need to be at that level of care, but do need some supports at home? Is that part of the conversation as well?
Yeah, I think so. I mean, this study was particularly just looking at a moment of time and trying to understand what was happening, you know, within the people that were living in the SNFs. But, you know, thinking about the transitions, both when someone goes from the community to a SNF, and then, you know, the opportunity to go from a SNF home, and how do we have continuity of service on the mental health, you know, side, I think is a really important systemic issue. And, you know, when people are coming, if people are coming from the community and they are connected to mental health services already, those services, those providers don't go with them to the SNF, right? They lose that connection and they have to kind of restart at the SNF. So I think thinking about, you know, again, from a whole person care perspective, how do we have continuity of services or make transitions as seamless as possible, both when you're going in or coming out, I think are really important elements. And again, I think a lot of these recommendations, you know, do apply to people living at home as well, right? Like just the inadequacy of the supply of mental health services that are covered by public insurance impacts both sets of folks.
Yeah, that's a really good point. So getting on the staffing, I'm curious if, we're hearing just sort of across lots of industries, staffing is a problem, right? From airlines to restaurants to, I imagine, hiring folks in nursing homes. Do you think that's something that will have to be addressed? It's tied to reimbursement, right? It's sort of a two-part question, right? You talked a little bit about the low reimbursement, Medicare, Medicaid, which supports a lot of these folks in the public insurance. And so then on top of that, maybe having a hard time recruiting folks without offering, bonuses or larger, payments for that work. What do you think about that as a potential, challenge, new kind of challenge that we're facing along with many other industries?
Yeah, I think there's also, I don't think there's a silver bullet. I think, everything we've heard about in terms of the larger economy, looking at the fall and a combination of when schools are fully reopened, vaccination rates continue to improve, and people are less scared about actually working, unemployment benefits when those, run out. I think all of these factors are mixing into the larger sort of macro picture of why, and the quick spike in demand that, businesses just can't ramp up as quickly. In terms of, thinking about SNFs in particular, again, it's related to the turnover, to the low pay, to the wage, to the long hours. And I think that until you change the economics a little bit and make it, overall improve those systems around, the reimbursement rates, as well as, thinking about an influx of state and federal money to help bolster these wages and bring down those ratios. I think it's going to be this turnover is going to be a continual issue. These are hard jobs, right? Whether you're providing in-home support services or services within the SNFs. I think those kinds of issues actually cross again, both in community as well as institutional care setting.
Yeah, I think kind of the low wage issue can't be overstated. So just kind of in San Francisco in 2020, the median salary for one of these nursing assistants was about $35,000. And kind of as everyone knows, the cost of living in San Francisco is high. And so many of these staff are kind of commuting were commuting hours away, before the pandemic, during the pandemic. And so addressing, and if they can do a much less kind of physically and emotionally challenging job for a similar wage type, you would expect that a lot of people would rather do that. And so kind of really just needing to address that wage issue as a big systemic problem.
Yeah. Workforce development, career pathways, these sorts of things, right? That make it a more viable long-term career.
Yeah. Right.
Yeah. And I think to the extent that, some of the lower hanging fruit around piloting therapeutic practices and, trauma-informed care, to the extent that you're addressing the mental health of the residents in a more meaningful way, then that impacts staff too, right? Because it's not, if they're able to if the residents are doing better, then the staff are gonna be doing better, and vice versa. If the staff are really burnt out, that's gonna reflect on the residents. So I think, a lot of these issues are really big issues that are not going to be resolved in the short term. But I think some of these pilots could help build a case to say there are things we can do in the meantime, right? We can try some of these practices, effective practices. We can evaluate them. We could see if we can then replicate them at the state level. This is part of integration of, mental health and physical health services. Where better to do that than at SNFs, where you can have that opportunity. So I guess I don't want to, these big systemic issues feel very daunting, and we need to look for opportunities at the state and federal level to advocate for these changes. At the same time, I think there are things we can do in the short term.
Mm-hmm. It can just be done to kind of replicate those things that we know work well. Yeah. Mm-hmm. So what kind of activities would be helpful from the collaborative? We obviously are, a group of folks very aligned and interested in supporting older adults and those with disabilities, and, maintaining care in the right settings and supporting them and making sure they've got, the right care, and that these sorts of issues are addressed. What would be, your wish from the collaborative, if you had your pick.
Yeah, I'll start, and then Nora can add if she has anything. I mean, two things from my lens. One, I know you have your ledge group, as you're looking at legislation, taking on, positions that address some of these systemic issues. As you're working in regional collaboratives around the local playbook for the master plan, again, thinking about how pieces of this may fit into your agenda so that we're all sort of singing to the same note in terms of this is important, these are important issues to address. And then I would say, to the extent that there may be philanthropic partners and SNFs that are part of this group that might want to get some partner to pilot some of these practices locally and build the evidence case in an advocacy case to then say, okay, there are things we can do now that are not going to blow the budget, and let's do that. So I think those would be the things I would suggest, and helping to socialize the report. So yeah, again, looking for opportunities to partner on advocacy, on the advocacy side, looking for a way this work may be embedded into local master plan work. And then looking for any opportunities at the local level to pilot these, and we're happy to support or do anything we can to continue to raise awareness.
Yeah, helpful to have some of those details in the advocacy. Nora, did you have anything to add to that?
Susie pretty much covered it. Good job, Susie.
Great. Well, there's also here in the last comment here that there has been a concept to fund long-term care through a public benefit funded by a tax, which of course is never popular, and it failed with Senator Kennedy, but the idea that maybe a public-private partnership is the way to kind of pursue this and think about financing it, because we know none of this, over time it may save money, but it involves some real investment up front in lots of these areas. So thank you so much for your time and all the information. We did put a link to the report, and we'll go back out to folks on our listserv so we can make sure to socialize it and use it in our advocacy. Really helpful to have some of these, details and data that show what a lot of us, know to be true from experience and the work we do, but nice to have some of these resources and tools. So thank you so much for joining us this morning. We welcome you to stay and hear the rest of the conversation, and have a great weekend.
Thank you. Thanks again for the opportunity.
Of course, thanks so much. So we're going to move on and just quickly give some updates here about California Advancing and Innovating Medi-Cal, CalAIM, which many of you are familiar with. So just going to do some quick, summaries to highlight information that we know, and just as level setting, and then quickly highlight some of the updates that are coming along as these proposals move through the waiver approval process and through the legislature. So here's just a high level timeline. They were engaged in public comment for their draft 1115 and 1915B waivers to implement the several components of CalAIM. There is now a public comment period for the 1115 waiver. There is no federally required public comment period on the 1915B waiver side, which is really the managed care programs are all moving back under that 1915B structure rather than the 1115 waiver, which is used for kind of the rest of the components of CalAIM because they are broader than just the managed care enrollment sections that need to be approved through the B waiver process. And so before the end of the year, when the current Medi-Cal 2020 waiver expires, we will have to see some sort of CMS approval of both of those waivers. And then of course, flipping over to the beginning of implementation of CalAIM on January 1, 2022, with some things happening at the beginning and then more coming along. So moving to the next slide. We're going to go through some of the updates. Next slide. Population health management as one of the kind of overarching themes of CalAIM and requirements on the managed care plans to have population health management strategies. So the detail here shouldn't be anything new necessarily, but they did actually delay it until January 1st, 2023 to give the plans more time to really have a comprehensive strategy. You can see under here, they have to develop and maintain person-centered population health management strategy. They have to submit the local population health management plans, do some data-driven risk stratification, predictive analytics, and standardized assessments. So just recognizing it may take a little bit more time to get all that in place, really focusing on preventive and wellness services and outcomes during transitions. And so DHCS is also going to have the opportunity to have some $30 million appropriated in the budget to help with this population health management strategy. That will provide some access to administrative and clinical data that will really help plans kind of see that bigger picture to develop these population health management strategies. So the update really is that money in the budget and the delay. So moving on, managed care plan model requirements. So the model of care document is they're starting to roll in. The first one was due just earlier this month. And they really require some detailed policies and procedures about provider contracting and network capacity, given that under the enhanced care management and in lieu of services, there's going to be maybe some new provider types or transition of providers that have been under whole person care or health homes pilots through the counties. Will now have to work with the health plans as those dollars will flow through and those benefits be provided by the health plans directly. And so there'll be a couple rounds of these model of care documents, as you can see, as they sort of transition those populations over and expand the eligible populations over time. So they're going to start with the folks that are already getting these services through the current pilots that were authorized either through the Health Homes Program or through whole person care in the current Medi-Cal 2020 waiver. And then they will expand those populations in those counties and then expand other counties. You can see that there's several sort of versions required as they move through that continuum of population. Next slide. The enhanced care management benefits. This is just kind of an overview. None of this is new. I won't read them all. It's building again on the health homes and whole person care pilots, starting by transitioning those folks so that they don't kind of fall off a cliff when that waiver ends. So making sure they have something to transition to, and then you can see the list of populations of focus there. So next slide. So the changes here, the updates are really around just kind of phasing in a little bit more strategically. So on 1/1/2022, when CalAIM goes live, there will be a statewide launch of in lieu of services, and then the transition of whole person care pilot and whole person health homes members. So they will identify those folks that belong to a population of focus, and it will go live for the following populations: those experiencing homelessness, high utilizers, those with SMI and SUD, and adults and children transitioning from incarceration. And then a year later, they will increase those populations to additional populations of focus. And then halfway through, in about 2 years, they will go live for all populations. So just more of a phased in timeline there. Next slide. So for the non-whole person care and health homes counties, there is a slightly different timeline because they recognize that they don't have those populations necessarily getting that needing, to have transition immediately, because they're not necessarily getting those services through a waiver program at this time. So they will go, again, there's still a statewide launch of in lieu of services, which is of course optional for the plans and for the beneficiaries to take up those services. So that goes, that will go statewide regardless of what type of county, and be an option for the Medi-Cal managed care plans to offer and for the beneficiaries to take in lieu of a different service that may be more expensive or not quite as appropriate. So the non whole person care and health homes counties will go live next halfway through next year, so 6 months or 7 months after those other counties. And they'll start with those same populations. They will start with their model of care documents and show how they will grow network capacity over the first 12 months. There was originally a requirement that they have the ability to provide it to any eligible individuals immediately. And there was some feedback that building up those networks, especially in those non-whole person care and health homes counties, where they're not currently have those networks through the county development of those waiver programs over the last several years, that it would take more time to build that up. And so giving them a year to make sure that it is really available to anybody, that there's capacity within their network to provide it to anyone who meets that criteria. And then again, 6 months later, increasing the populations of focus, and 6 months after that, going live for all. Next slide. So again, this is not new. You've probably seen this. This is the list of potential in lieu of services that again can be offered at the option of the health plan, and then can be accepted at the option of the beneficiary. I won't go through them all. This is just to level set, a reminder of what we're talking about. Next slide. The policy changes or things that we wanted to just quickly highlight is, again, as I've mentioned, it's voluntary. Plans are not required to offer it, and enrollees are not required to accept it. And the plans may add additional in lieu of services every 6 months. And if they do offer it, it's not required. Again, this was a shift, not required to be offered countywide, but they have to demonstrate that they're working towards building that capacity to have it available countywide, so that as time goes on, folks will have access. So enhanced care management and lieu of service incentive payments. So again, there is a recognition, like we were talking about in the last session, that there is some, significant startup costs to developing some of these initiatives and being able to deliver this care. And so they do budget a significant amount of money for incentives, and some of the details about how those incentives will be allocated is starting to come out of the Department of Healthcare Services. So $300 million in that first 6 months, and then ongoing $600 million in the 2 subsequent years. And then it will phase out in fiscal year 24-25. There is a whole process that they're using to have the plan submit their sort of gate, as they're calling them, activities that meet certain criteria. And then if they meet those, then they get to move to the next phase of ladder, sort of increasing that funding, and then they will be able to use that for infrastructure, workforce capacity, and really it's intended to help, especially these initial incentive payments, to help the plans build up their enhanced care management in lieu of services capacity, and drive their investment in actual infrastructure, because they're one-time funding that's meant to get it up and going and not be an ongoing cost, and then incentivizing them to really take up in lieu of services, because once again, that is optional, and recognizing that they may need to have some upfront incentive and funding to help increase the take up by the managed care plans of the in lieu of services benefit. So we can go through this. I don't need to walk you through each of this. These are a little bit more of the details of how they will go through and give this to the plans. The plans have to submit a gap assessment and a gap filling plan to get some of the dollars, and they will be tied to performance targets, and they will not receive all of the funding that they ask for until they meet all of those gap filling targets. So more detail there available if you want to look at that when we send out the meeting materials, but I don't need to go through step by step. And so the next piece of this is that there will be a high performance pool allocated for unearned incentive dollars. So understanding that it may be hard for the plans to get meet all of those goals, or maybe, will be ambitious when they first submit these plans, that if there are unearned incentive dollars, they will go into a high performance pool that will allow other plans that are meeting minimum requirements and high performance targets. They will be able to use those dollars. And so really trying to incentivize those folks that are kind of going above and beyond. They have to be offering at least one in lieu of services, and then they will set some sort of parameters about, the percentile that they have to meet in order to get these high performance pool dollars. So just another way to provide incentives and to really get the funding out into the system. Next slide. I will also just say quickly on that last one, before we move on to this dual eligible piece, is that they did actually also clarify that they will be providing kind of extra incentive dollars to those counties that don't have whole person care or health homes pilots, in consideration that those counties have already had significant investment through those previous waivers, and that to sort of help all boats rise, they will help those counties that have not had that money flowing in over the last several years. So just another kind of interesting policy clarification that's come out recently. So then looking at the dual eligible special needs plans, you've got the CalMedi Connect program coordinated care initiative, which I know many of you are familiar with, are really are ending at the end. And so there's got to be a transition specifically for the populations in the CalMedi Connect program. Other portions of the CCI will sort of continue through managed care contracts on the state side, but really the big push here is that there's got to be a transition for the end of the CalMedi Connect program and the folks that are in those pilots. And so two of the pieces here related to CCI are the CalMedi Connect program and then the transition over time to manage long-term services and supports. So the first piece that's sort of pending here is that there'll be a requirement when CalMedi Connect ends at the end of 2022. The CCI plans will transition their duals to what's called an aligned DSNP. So instead of having under CalMedi Connect one aligned model, you have dual eligible special needs plan that's required to have a contract with the state to talk about how they'll share data and how they'll sort of coordinate care more than original Medicare, fee-for-service Medicare, or another Medicare Advantage plan. So some extra requirements on these dual eligible special needs plans. And so that will happen for those CCI plans in 2023. And then there'll be some shifts to sort of not allow additional DSNPs that don't have a Medi-Cal managed care plan over time, so that there's really an incentive if you are going to enroll in an integrated product that it matches your Medi-Cal plan. Lots of details still to be worked out. And then they'll also transition to a statewide DSNP requirement over time envisioned for 2026. And then there is also in the proposals, I'm sure you're all aware, a reference to in 2027 moving to MLTSS statewide. And so some of the more interesting updates here is that they're getting some pushback from plans that don't currently have dual eligible special needs plans or CalMedi Connect product, on that it's a kind of heavy lift to get all that up and going. And so they are going to conduct a feasibility study about the financial ability for plans to bring up dual eligible special needs plans under the current structure. And then at the discretion of DHCS, they will decide if there will be any waivers, which is a real shift from the original proposal, which was, a mandate of alignment and consistency of the benefits statewide. And there you can see there's a bill there that is going through the process. So next slide. So just quickly, here are some of the upcoming meetings. The DHCS has MLTSS and duals integration work group meetings. You can find those on the website. There was one just this week. They have their larger stakeholder advisory committee and behavioral health stakeholder advisory committee, and then lots of activities going on around CalAIM and all of the initiatives. So just check their website, get on their listserv if you are interested, as these implementation deals all start to get put into place. So that is all we had for today for the updates. We'll quickly see if there's any Q&A.
Thanks, Athena. And I'm happy to moderate Q&A. I'm wondering, Nancy, if you could just spotlight me. It's not giving me the option to do that, even as a host. So thanks so much. I just have one kind of really quick point of clarity to ask about. We're sort of wading through this content, and there's so many acronyms to think about. So when you talk about enhanced care management going live for populations, specifically adults with SMI, SUD, what does that acronym stand for?
Seriously mentally ill and substance use disorder. So those folks have some behavioral health issues and substance use disorder.
Thanks so much, Athena. And Randy, I see that you've popped something in the Q&A. It seems like it might have been cut off, so feel free to raise your hand. I do want to recognize that we have a couple of collaborative members who are involved in the Collaborative's Integrated Service Delivery Work Group on today. And Marty, I know you've got a jet, so I'm hoping you're still on and can kind of share your thoughts, and then maybe we can turn to Pat after that.
Yep, here I am. Thank you. Athena, that was quite a mouthful there. That was a lot of detail. So, I guess what I would say about CalAIM after listening to that is I've seen CalAIM as a real long run an opportunity for us who are interested in improving Medi-Cal and seeing more of an integrated system of care for folks who have complex needs and need to not have to manage all of that detail, right? So the MLTSS, the duals and DSNP work, all are potentials, but really the ECM or enhanced care management, ILoS, are much more right in front of us now, right? So I've been interested in that. And I'll admit that I maybe naively thought early on that ECM particularly sounded so good. And for years, we've wanted to have all of our Medi-Cal beneficiaries who needed it have care coordination, case management, that sort of thing. I was really hoping it would be one more step in that direction. Well, maybe it's a step, but it's a little step for sure, because when the state talks about this, and this struck me, they talk about a triangle. If you think of all the Medi-Cal beneficiaries in a triangle, the folks at the very tippy top of that triangle are the ones who probably will be eligible for enhanced care management, just like whole person care and health home in the past. And then even after the nursing home transition and the populations that might be more of interest to the older side of the house roll in, I think the concept is still the same, that we're talking about the people at the very tippy top of that triangle of need. So really people with very complex problems, probably high costs and such. And below that are most of our constituents and most of the people on Medi-Cal. So I think what that points out to me is it's still so important to work with the health plans around, and our providers, including ourselves, around normal, I'm going to call it normal, care coordination and case management, because that's still how most of the people are going to get whatever help they're going to get. It's only a very few that'll get the enhanced care management and be eligible for it. And from the provider side, on our side, who maybe have offered these services, there'll be rates for those very few people, and we'll get paid for those, as maybe some of us did for whole person care. But what happens below that is still, I think, up in the air, and whether the plans really have incentive to care manage and care coordinate for the folks with lesser levels of needs, and how we get supported to do that work still remain open questions. So I hope we'll keep making progress on that. And I think that's the hope, that's the opportunity, and maybe that's in the population health management side, if you think of it that way. But there's some work to do, and the ECM really will be a pretty targeted benefit, as I understand it at this point. And Athena, I don't know if you want to comment on that, but that's my overall thoughts on the issue right now. Thank you.
Yeah, I think that's right. I mean, I think, ideally, right, they put out this big, broad, picture, and now we're getting down to like what's really feasible and what's the focus. And, with both whole person care and health homes, specifically health homes, there was really some requirements that the folks that were enrolled were those high cost, high utilizers, right? That they had to use data and pull, that their target populations were those people who were really using, the services at a high rate, and, they could see from the data. The problem has always been that then you're not getting to them until that point, right? And so if you could get to them before they become the high utilizers, right, when they need lower levels of care, that's ideal, right? By the time they're sort of hitting your radar on the data, it means they've already fallen off a cliff a little bit, right? And sometimes you can't prevent that, but often, getting to them before that. And so I think some of this population health management, data exchange, predictive analytics is supposed to help build that out, but all of that, of course, does not turn on overnight. And so, yes, I think you're right. They've found that they can't just turn on ECM for everyone overnight, but that, starting with those folks that are currently getting the services from those pilots is the way to make sure at least they don't fall off the cliff, and then kind of build from there. So I think, yeah, keep marching on, Marty. There's work to do for sure.
Thank you.
Thanks, Marty. And I do want to turn to Pat Blaisdell as well to hear her thoughts. And Randy, I see you've got your hand up. We'll swing back around. I promise we will. I won't forget. Pat, I've opened your line, but you may need to unmute.
Okay, here I am. Thanks very much for this great summary and for the opportunity to share my perspective. And I really want to acknowledge and underscore the comments Marty just made regarding the need to continue to focus on access to care coordination for various levels of need and on a proactive basis. So I think, you stated that so well, Marty, and I think that's an area that we as the collaborative can really provide some advocacy for and some support for continuing forward. So from my perspective, I think the areas of focus, again, much like Marty commented, very excited to see the emphasis on enhanced care management, which I take as a recognition that some patients, and perhaps more than are currently being targeted, really need to have that very specific and coordinated care management that links between medical care services and other services that could be offered within either the enhanced care management program and as well as in lieu of services. So concept is great. We're very supportive. The state is moving in this direction and excited to see them putting attention and resources there. Our concerns, not unlike some of what Marty voiced, is really about ensuring some consistency. I think in the early drafts of the ECM, some of the definitions, and this really gets at some of what Marty was talking about the scope of the access, were pretty vague. I mean, a high utilizer, well, what's a high utilizer? And will this plan define the high utilizer the same way as this other plan defines the high utilizer? And what does that mean for the consistency of access for the beneficiaries who need this care? Well, in the final draft, they did come down with a little bit more specificity in some of the definitions. So that is helpful. I still question whether or not the number of folks that they're estimating would fall within those definitions is the same as what the plans will identify. And about those folks that might be a little bit borderline, that are just edging up to that cliff that Athena mentioned, how we can address those and identify those. So I think we're still watching carefully that as ECM becomes implemented, that there is a consistency in application and some attention to ensuring the folks that really can benefit from the service are actually getting access, not just access kind of on paper or in data points, but true access to the services they need. Our comments to date, CHA's comments to date on ECM and ILoS have really been informed by our experiences with the Coordinated Care Initiative, with Managed Long-Term Services and Supports, and with the Management Medi-Cal benefit to date. And that is, we have, again, we think everything on paper looks really good in terms of the direction we're going in. What we're concerned about, have always been and continue to be concerned about, is ensuring that there is a clear accountability for the plans that are providing this care. We know that they're responsible for the behavior of their delegated entities. That has been a challenge when we're talking about delegation from a plan to the physician groups. And now we're talking about delegation to a number of ECM contractors. So we just want to raise the awareness about ensuring that the plans have a mechanism to ensure that their contracted ECM providers are providing the services they're supposed to, and B, that DHCS and the plans have a way to communicate and ensure that's happening. So we are maintaining our focus on the accountability, the follow through, the ability to identify and address problems both on an individual and a systemic basis. Those are the things that, as we move forward with this very exciting and worthwhile move forward, that we are also ensuring that we're not just talking the talk, that we're walking the walk at the front lines. So I think that's kind of the major issue that I've been focused on in our comments and our discussions with the department and on the drafting of this process. Also, just some clarification on operational communication. If I'm a case manager in a hospital and somebody who is homeless presents to the ED, how do I know who is in what plan, who has what ECM provider? How do I know who to access to help coordinate? It sounds like a little thing, but it can be a huge barrier to actually making this program work as well as possible. So I look forward to continuing to work on clarifying those kind of nitty-gritty operational issues, as well as the overall oversight. So, and again, thanks for the opportunity to weigh in.
Yeah, no, I think those are all great comments. And the data, right? That's been the challenge, and so, even, there's a lot of hope around the use of the ECM providers and sort of network and building more on what we saw some of in the Coordinated Care Initiative, but not as much as folks had sort of hoped. And some of the challenges is that those smaller, providers don't have the same capacity, to report up all of the, services that they're providing. And so you've really got to build that data infrastructure, and the plans, I think are aware, and some of the providers are sort of like, oh gosh, we don't, we don't want any of this. Can we just get a grant and keep doing what we're doing? We don't want to have to, pay. I've heard, that some of the providers are even asking, say like, well, if we want to have this contract, you're going to have to fund a position at our organization just to do the data, because we don't have time. You need that data, right? So, I mean, these are some real conversations, those operational things that, again, it all looks great on paper, but we've got to get down to those details. And I think, the more the department hears from all those perspectives, the more they can hopefully, integrate in and think about how to use all this infrastructure, funding that's available to kind of think that through. So really good points, Pat, and hopefully we'll see some of them resolved over time, but none of it moves quickly, that's for sure.
Yeah. All right. And I do see that, Debbie, you're on. I don't want to, I know you said that you've got a lot going on, so I don't want to pick on you. I'm just going to open your line if you want to jump in and make a comment. I know you've been involved in those conversations with the Integrated Service Delivery Work Group, and really the focus of that work group has been CalAIM for quite some time. So I see you've unmuted.
I am unmuted. Yeah, no, I was here. I thought I was going to be commenting on this, so that's why I put my stuff in there. I just want to express concern in a number of areas. I think that there's a lot more hope than there used to be in terms of the direction that we're heading, but I do still continue to see the optional nature of the ECM and in lieu of services being a statement that that our state is unwilling to commit to something we have seen over decades is mandatory for the people we serve, right? It may not be mandatory in the way that they've structured this, but people's lives don't work that way. And I think the points that Marty and Pat both made related to the care coordination, if we wait until people become high utilizers, we're ensuring that we're going to cost the system a ton of money. There's some upstream stuff we can do to prevent them from becoming high utilizers as opposed to reacting to once they are high utilizers. And I talk about this in the healthcare context, but in the human context, we have to think about the person. And why would we let somebody go down that path? I mean, not even talking about, sort of the health plan structure of it, but the human aspect. And I think we tend to lose that in conversation when we're talking about plans. I'm also really concerned that the incentive monies for in lieu of services and ECM are going to be used to build up health plans rather than invest in the existing community-based infrastructure that's there. And it will end up becoming competition, but they also just don't have the institutional knowledge that some of the providers have had with 4 and 5 decades worth of experience and more in many cases. So I think those are definite concerns to me, and we've raised them and raised them and raised them, and they were not addressed. They were not responded to. And my big concern is that Maya Altman, who is sort of like, I don't know, for many of us in the long-term services and supports and home and community-based services world, look to her as a leader in the managed care space. Like, if we could have a Maya Altman at every, managed care plan, I wouldn't be talking to you about my concern about these benefits being optional, because I know that they would be used. But as we saw in the coordinated care initiative, when services were optional, they weren't utilized by the plans. And so, she's retiring, ladies and gentlemen. This is a huge issue. It's a huge threat. And I think we need to, and no, she shouldn't carry the weight of the world on her shoulders, but those of us who have, worked with her and have seen what she was able to do when she put the person at the center of the plan, I just think that we need to rally around this. And I do believe that the California Collaborative should be putting forth during this comment period some very strong statements and going on record about all of the things that have been discussed today, and some guardrails around what those enhanced payments go toward. And yeah, I have lots more to say, but I will stop there. Thank you for the opportunity.
Thanks, Debbie. And I don't know, Athena, if you have a quick response, and Debbie, I do want to ask the question that you put in the Q&A, but I don't think it came up in your comments, and I think it's an important one. So Athena, go ahead.
Yeah, I would just say, yep, we should get the, integrated service delivery work group to draft up some comments. So we can put a call out for that after this meeting. Certainly a great opportunity to go on record, but to also, follow up more directly with the department and CMS, sort of engaging around these issues and the lessons learned. I mean, I think, everybody would like to see them not repeat some of the, lessons that we've learned through the coordinated care initiative. And so if there needs to be some reminders of some of the things, that didn't work as well that we could improve upon, now is that opportunity. And I think, the whole point of a demonstration, right, is to find those things that don't work and the things that do and build on that. I would say specific to the optional in lieu of services, the new carrot, so to speak, for the adoption, there's a couple pieces there. One is the reprocurement, right? So if plans are going to be bidding, they want to show the department that they are committed and that they're sort of like, yeah, we're taking it all on, right? You want to check all those boxes. So I think it's not 100% guarantee, but I think you'll see some increased uptake from those plans trying to make their mark leading up to the potential, reprocurement in all of their counties. And I think the other thing is that under the Coordinated Care Initiative and CalMedi Connect, the care plan options were not reimbursed. So that made it really difficult. So in lieu of services makes it so that those same sort of care plan options benefits can be built back into the rate, so you can account for those costs, and so it doesn't reduce your rate over time. So that is the really big shift here. Now, whether that will make a difference or not, I can't say, but I think that's the idea, is that they are actually recognizing there is a cost to those services, even if it's less than the cost of a nursing home stay or something else more expensive, that if you don't account for those costs over time, it erodes the base rate. So complicated financing stuff, but very important as an incentive to have more uptake.
Thanks, Athena. I think complicated sums it up for me. And I will do a little pitch and just say that the California Collaborative's Integrated Service Delivery Work Group has been talking about enhanced care management, has been talking about in lieu of services. And I think towards the end of the month when we do meet, we're going to continue that conversation and start to build out some recommendations and engage the department in these conversations. So if you're a member of the collaborative and you have a big interest in this topic and you're not part of the work group, just know that you're welcome to join. We'd love to have you. We'd love to have you participate in those discussions, and I'll drop my email into the chat. Feel free to reach out and we can get you added to those mailing lists. And Randy, I think we'll turn to you. Thank you so much for being patient. I know it's been a little bit of a wait, but go ahead. Your line is open if you want to jump in. Randy, you may need to unmute.
Here we go. So I have 3 questions. 3. 1, there's going to be a feasibility study. I wanted to talk about the feasibility study because 1, the last time they did a feasibility study with coordinated care, that didn't go so well. And 2, that kind of leads into the second question. What happened with coordinated care, not persons with just seniors enrolled to the coordinated care, the person with disabilities didn't enroll to coordinated care, and more likely people with mental health issues are going to be more likely to be people with disabilities and classified as disabilities, not so much as seniors. And number 3, it turns out that I'm on the behavioral work group, which I saw is going to be meeting in October. One of the things I wanted to know is I want to make sure this is centered with the clients first, because with coordinated care, they were so busy enrolling everybody in, they didn't really take a look what was going to happen to the client when they didn't have their fee-for-service program anymore, or they're being enrolled into another program in the county and they fell into the gap. And so this is a big issue. So I want to make sure that as a client and clients that we represent, that they don't fall into the gap when it comes to enrollment into CalAIM. And I understand why you're doing CalAIM. I understand it. There's savings there and all the good stuff, integrating programs to make it easier for people to get there. But sometimes integration doesn't always work because people don't understand what has happened to their program. And as a client, try to explain this to a client. And also, that was one of my questions too. As you guys roll this out, the more public transparency that you have on this, especially with the medical community, the more likely you're going to get it to succeed.
Thanks for that. I mean, definitely good points. I'll start with the feasibility study. So the feasibility study is specific to the requirement that statewide, the plans all launch aligned dual eligible special needs plans, which is a Medicare Advantage plan. And there is a big, heavy lift to doing that. There's a lot of Medicare requirements. There's a big bid process. There's a whole bunch of stuff that comes along. So for example, those folks like Maya Altman that run a COES plan, right? She happens to have been in the, Coordinated Care Initiative CalMedi Connect, so she has some of this, but her similarly aligned plans, they don't have to market, right? So they don't have marketing teams. So now they're going to have to bring up an entire marketing team in order to meet Medicare requirements. They're going to have to do enrollment. Right now, they don't do enrollment because everybody just goes into their plan. So they have to do that. So there's some concerns from some of those plans about, you want us to make this big investment, and build it, and the timeline's pretty quick. And so some of them have run feasibility studies. And so the state is saying, okay, we've heard you that maybe it's not financially viable right off the start. So how do we, look at that and see what that looks like for some of those plans that haven't already entered that market through CalMedi Connect, or some of the other plans that have just developed Medicare lines of business over time. So that feasibility study is specific to that specific requirement. And then the state may decide to give certain plans and certain counties waivers if it looks like it's really just not viable to have that type of plan in the market. So it's a pretty narrow focus. And we don't know if it'll actually result in any kind of exemptions or waivers across the state. But they have pushed that back another year in some trailer bill language that we'll be seeing shortly. So really just giving more time to decide what the best path forward. In concept, there's agreement that integrated care is better. It's just figuring out the steps to get there and how feasible it is. For the gaps, I mean, I think you're right. You identify some of the problems of people falling through the gaps. Transitions are hard. I think helping any feedback on ways to do outreach, right? Help from community-based organizations, help from providers at the front line of how do we communicate effectively, so that as a collaborative, working the plans, the providers, the, community support folks, everybody has to kind of help, think about strategies that work to really engage consumers and help them understand, and then help them to get access to those services that they're, eligible for. So I think increasing access and increasing, member and education is really key to that. And if you have strategies on that, I'm sure the department encourages you to share those with them.
Thanks, Athena. And sorry, did I cut you off?
Nope, go ahead.
I was going to say there is a comment from California Health Advocates. I suspect it's Tatiana, it might not be, but she wanted to share that one serious concern that California Health Advocates and ombudsman have is the impact of CalAIM on skilled nursing facility residents, because it's going to depend on providers willing to be part of managed care plan networks. There will be major disruptions. And yes, it's Tatiana, thank you.
Yeah, I mean, I think again, there'll be, there the long-term care benefits being carved in, statewide. It's already exists in the CCI counties and in most of the COES counties. And so that transition for those additional counties will, come with some transition disruptions. I mean, anything, no matter how well it's planned and the best of intentions, there's always hiccups when you transition something like that. The plans will have to go out and build those networks or pay out of network. I mean, there's all sorts of things that go into that, but it's definitely something to raise, something to watch. Again, thinking about how to do that provider, education and outreach about, this is the system and, let's see how we can work within this new structure, and also to beneficiaries and their family members or those supporting them to better understand what this means, for them, and any changes that might be important for them to understand as that happens. But yeah, I mean, no doubt carving things in or changing the delivery system, can have some really good benefits over time, but it can be bumpy to get there. So I definitely think, again, share with the department all those pieces. They've got a lot to think about, and there's always, unintended consequences or things that happen along the way. So encourage you to share those with the department.
Yes, thank you, Tatiana, and thank you, Athena. I'm not seeing any more questions in the Q&A. I'll pause for about 7 to 8 seconds to see if anybody wants to jump in by using that raise hand feature. That'll put you in the queue. We can open your line if you have something you'd like to share or ask a question. And if not, I think we are right about at time anyway, so we can probably close out. just want to thank everybody for joining us today. We'll make the recording, the slides, and the link to the skilled nursing facility behavioral health study available to you early next week. I think some of those components are already on the collaborative's material page, so I encourage you to go there. And just again, thank you. Have a wonderful weekend. We look forward to continuing these conversations, continuing to be engaged. All right, thank you so much.